Okay, so I think people are carrying on trickling in, but we'll say hello so that you know who we all are and that we can get started. It looks like there's lots of people with us, so thank you very, very much for giving up some time on your Friday morning. We'll just quickly introduce ourselves. We won't go round the whole room because I think that would take up most of the hour. We have already received some questions, so that's really appreciated, and we'll tackle those first. And then we will open up the floor to any other questions that we haven't had sent in advance. So hopefully some of the questions that have already been asked might answer some of your questions. So if we introduce ourselves first, I'm Louise Clark. I'm one of the Associate Directors, looking particularly around the post-acute part of the pathway, and I'm a consultant therapist, an OT by background, working in Dorset. Rebecca, should we come to you next?
Yeah, hi, I'm Dr. Rebecca Fisher. I'm also an Associate Director with SNAP. I work with the Clinical Policy Unit, focus on rehabilitation, and I work at the University of Nottingham.
Fariat?
I'm Fariat, the Senior Operations Officer for the SNAP post-acute work.
Lovely. And last but not least, Anissa.
Hi all, I'm Anissa. I'm a SNAP project officer assistant with the project audit.
Lovely. Okie dokie. Thank you. So that's our little lot. We are recording the session is the other thing just to say, just to make you aware, and then that obviously can be shared with other people. The answers from any questions that are raised today will also be put on the frequently asked questions section, and anything that we feel is needed to be updated in the help notes to help other people, then we will update those as well. So thank you. Last thing to say before we get onto the questions is that these sessions will run every week. So we've got another few of these through April for the whole time that the audit is open, and welcome to come back to any other sessions or drop us other questions. Obviously, we are available in between times as well, as are the help desk. So you don't have to limit your questions just to these Fridays, but you're very welcome to come back. Okay, so before we move on to the 9 questions that we have got, can I ask if anybody else has got a question for you to pop that in the chat, just so that we've got an idea of the number of questions that we're going to need to get through. Like I say, some of them may well be answered as we go through those initial 9, but at least the rest of the team can start to have a look at that whilst we're answering the initial questions, so thank you. Okay, so I'll just take us through the first question that we've got and pass that to Rebecca. I've got somebody that can't hear. Can everybody else hear me? Yeah. Fab, thank you for the thumbs up there. Good. Okay, so question 1 then was particularly in relation to Wales. So I don't know whether we've got any Welsh participants with us. Perhaps if you could put your hands up or say hello in the chat, that would be helpful. So particularly asking around the questions about joint health and social care plans and how does that relate to Wales, and also people being discharged into a team with access to commissioned services for emotional, social and practical support, and how do they best answer these? So, Rebecca, do you want to give some clarification around Wales for us, please?
Yep. May I just ask, we unmuted everybody so that you could actually participate, because before we've all been muted, it's been difficult. But may I ask that just for now, if you can see your mute button and it's sort of going green, could you mute yourselves? Because you can easily unmute if you want to ask a question. It would just help with feedback. Sorry, my computer's terrible. Thank you. So with regards to this particular question, so the first question related to question 1.9, so are people with stroke discharged with a copy of a joint health and social care plan? And so in the help notes, which Fariat's just scrolling through, we do clarify what we mean by a health and social care plan, so a document developed to address the patient's individual needs, that's evidence of joint care planning between health and social care. So it's really just to demonstrate that's in place, that link between health and social care. The other point is around, as Louise said, access to the provision of emotional, social and practical support, for instance, by the third sector or charities. And so really we've just clarified that we mean commission means refers to required for Welsh NI clarification. So it's basically just asking, are patients able to access those required services for the emotional, social and practical support? So yeah, replace commission for required. So hopefully that explains it, and back to Louise.
Lovely, thank you. If there are any Welsh or Northern Irish teams that are on the call, then if that hasn't clarified things, then do come back to us in the chat and we can come back to that. But thank you, Rebecca. Okay, so question 2, and this may well be relevant to other people on the call. We are a specialist commissioned standalone service for all neurological conditions. However, our caseload is not at least a third stroke, but is more than 20 patients a year. So what would we answer for 1.3? So 1.3 you can see is there. So the answer to that question would be that, as it suggests in the help notes there, you would respond as number 2, so stroke and neurology patients. So that's absolutely fine. The next question is around question 1.7. We do have access to referring to OT SALT psychology, as we're a specialist centre, but our staffing and organisations are separate. What do you think I should answer for this? Ideally, it's a yes, but not within our service, but then they would be being asked to report for a different service. So in summary for that, what this team I think is saying, and this is Oxford Centre for Reablement, so identify yourselves if you're here, is they refer to OT, speech therapy and psychology, which is a service that sits outside their team. So for that, you would be saying that you do have access. So the second bullet point on the help notes there, you do have access, but these are not based within your service. Okay. So that is fine. We would hope that the service that you are referring on to are also registered, and therefore we would have a lot of the information coming from them. Okay. In terms of answering the questions around how long until that person is seen, so some of the other questions that sit under that, we would still be asking you to answer that question. All right, so you yourself as the referrers having an idea, it doesn't have to be absolutely accurate, of the length of time between when you make that referral and when it's picked up by the team that you are referring to.
I don't know if possibly elementary because it's CNRS are putting in.
Sorry, may I ask people to mute, please? Thank you.
Okay, I can't see the chat very easily. So Claire Lee, referrals being picked up. So I don't think that's in relation to what I've just answered.
No,
Hopefully that's a separate.
Yeah,
Lovely.
there's more questions coming in which we will pick up after we've gone
Great.
through one. Yeah.
Okay, so hopefully that makes sense for question 2. If anybody wants any clarification on what I've just said for question 2, then let us know now before we move on. Okay, so if you're referring, if you've got access to any discipline, OT, speech therapy, psychology, that is outside of your service, then it's a yes, we have access outside of our service, and then we would still ask you to give the times around the wait for referrals, etc. Okay, thank you. So question 3 is from a CRT, Kings Lynn and West Norfolk. What is the average number of vocational rehabilitation sessions that are provided per patient? And the team have let us know that we're struggling to put a figure on this, as it is very dependent on the patient, the presentations and their individual aims. How would you advise us on this? So Rebecca, can I pass this one to you?
Yeah, no, I think it's a really good point. And we did have some internal discussions about this very issue, but felt it was important, particularly for standalone vocational rehab services, that we get some indication of sort of the amount of time that was provided to the stroke survivor. I mean, what we can only say is we understand it will vary from patient to patient, but we're really looking for an average, which I know is kind of sometimes quite difficult, but you know, I think there is obviously going to be a stark difference between a couple of days a week versus once a month or once every 6 months. So I think we do understand that there's going to be tailoring for each patient, but it's really just to get a feel for the intensity that's being provided. Would you, anything you want to add, Louise, with that?
No, so I think that kind of level of pragmatism is really what we're asking for across the board. So the same with waiting times and things like that, where we're asking you to give, you know, average number of sessions or average waiting times. It is really looking across the caseload and what's the most sensible answer given that variation. We're not expecting you to go through absolutely every individual record and add it up and divide it by the number of people that have been seen. So just a sensible, pragmatic look at the data and what your service generally experiences in terms of average numbers or average waiting times. Okay, so we recognise it's still really busy out there clinically. We've still only got a month for you to upload the data, so we do not expect you to be hand picking through every single record to get the exact number of days wait or the exact number of sessions. So just a pragmatic, data informed, as accurate as you can, best estimate please would be really appreciated. Okay, thank you. So question three we've just answered. Question 4 is about 1.7. Can we go back to 1.7, Fariat?
And Louise, there's a question in the chat about this as well, to do with proportion of whole-time equivalent. So I think once you've answered this, we could perhaps cover that one as well. I can help you with that.
Lovely. Okay, thank you. So question 4 was from a combined ESD, CRT and post-acute inpatient team, and they've given us all of our SNAP codes, but I'm not clever enough to know which teams those are. So thank you. Hopefully you'll recognise yourselves. So their question is that the table is asked for total whole-time equivalents in section 1.7. Is this the funded establishment, or should we include any additional staff for whom we have not got funding? So the answer to this question is, what is your budgeted establishment? What is your commissioned service? Okay, so that is the budget that on paper at the moment is designated to that service. Okay, as per all of the questions, we've got a caveat around COVID. If during COVID you have had additional staff redeployed into that service, who are now going to become permanent, but that is not currently on your establishment and that is not currently in your service specification. But for all intents and purposes, your managers are telling you that this isn't going to go back, this is not temporary, they're permanently going to be with you, then you could report those as additional to what's in your budgeted establishment. If it's just a temporary thing, just tell us what your commissioned budgeted establishment is.
Yeah.
Rebecca, anything to add to that?
No, that's fine. The questions in the chat relating to this, and I was just pondering over it myself. So I think Fariat would be useful for you here. So it says, how do we record whole-time equivalents of staff members if team is stroke and neurology? Do we record whole-time equivalent of the team or proportion of caseload that is stroke? So my answer to that is, just starting with the caseload bit, we do ask for numbers of stroke patients, but also the total number of patients. Is that right, Fariat?
Yeah. That is right, Rebecca.
And then the other thing is, how do people then return whole-time equivalents for staff members? So I just want to make sure that we refer back to the help notes for that, because I think it's important. I mean, from our perspective, we do want to understand that there's appropriate resource for the stroke patients, but I understand that you're resourced across the team as a whole. So
yeah, sorry, I was just trying to unmute myself. Yes, we do ask for that in 1.6 and 1.5. About stroke patients, and then we asked about all patients as well. So when you're putting in I guess, is that question in relation to 1.7? I guess they were put in relation to the stroke patients for 1.7.
Sorry, I would think opposite to that personally. I think that we would be asking the teams to put in the whole time equivalents across their whole service, and that then we would use the data to show the proportions. Yeah. So if you're a combined service that sees stroke and neuro patients in 1.7, tell us what your whole staffing is, your whole time equivalents, and then we would work out. Given that, say you've got 400 patients a year, you're telling us that 50% of those are stroke patients, we would then look at what that looks like across the distribution of the caseload. I think it's too much to ask you to be splitting up the whole time equivalents when in reality that's not how your services are working. You're working as one total staff group across conditions. Are you happy?
Yes, sorry.
Yeah.
I meant in reference to 1.5. Sorry.
So okay.
1.5. Yeah, it was me. I said 1.7, but I meant 1.5. So 1.5 would be stroke patients only. 1.6 would be all patients, and then 1.7, as Louisa just suggested, would be in reference to all patients.
And I think that's an important point, which is why I wanted. Why, you know, did you notice that I've definitely made sure that you two answered that question, because I think we have had a lot of questions around this, and it's not black and white at all. Certainly with regards to the inpatient beds, which is a different issue, but I think this is where we want to make sure that having these calls we're all on the same page with it. So hopefully that's helped to clarify that question.
And we will definitely clarify that on the frequently asked questions, and in the help notes, we'll update the help notes to reflect that. I think where we can, we're trying to be sensitive and sensible to your teams being able to complete this. We don't want you to have to go away and artificially separate things that in real life aren't artificially separated. So if your team sees all of those patients, you just tell us your whole time equivalents, and then we can look at the data to show us what that means. All right, so hopefully that's easier for you.
Yeah, I think the key thing just to add though is if we don't have the information about the other lot of patients, then we can't work it out. So I think it's just making sure that all the information's there. And at the heart of all of this, just to understand why we're asking the question, it's just to make sure that we understand from a staff ratio patient perspective that it's appropriate. So again, we're thinking, you know, if you were to get this information back, would you be able to make sense of it? And hopefully if you can, then we can, if that makes sense. So thank you.
Okay, lovely, thank you. So question 5. So this is relating to questions 1.4 and 1.5. If you're able to go back up to those, Fariat. Okay, so for question 1.4 and 1.5, as we receive referrals for stroke patients for just 6-week reviews, do we include these within those treated in the last 7 days and the number of new referrals, or is this just for those referred for having therapy input? So, Rebecca and Fariat, can I pass that one back to you?
Do you want to go first, Fariat?
Sure. So this was question 5.
Is it 5? Yep.
Yeah.
Okay, so they're referring to, I believe that they do the 6 months reviews. So we receive referrals for stroke patients for 6 months reviews.
Sorry. Yeah, sorry. I think the question's asking, correct me if I'm wrong, and it'd be nice for everyone on the call, is that...
Sorry, it was my question, I think.
Hey!
So if that helps. So we're a service who we have some funding to do 6-month reviews from a member of team within our service. So we get referrals for patients that have therapy and we'll automatically put them on the 6-month review list. But we also get referrals for stroke patients that don't need any therapy input and are identified as just needing 6-month reviews. So when we're asking for the numbers of stroke patients referred to the team, is that them in total, including the ones that only need the 6-month reviews, or is this purely to look at the therapy needs for those patients, and the numbers of 6-month reviews comes later in the data set?
I would say yes. I mean, based on knowing what I know about why we're asking whole time equivalents, it's really to understand the therapy provision. That said, of course, the fact that your service is taking on additional patients, so the wider caseload issues is obviously important, but I think with regards to that whole time equivalent, it would be in relation to therapy. I don't know, would Fariat and Louise?
Fariat, do you want to go first?
Yes, I would agree. By the help notes, we say that this is referring to the last 7 days prior and including both. This includes patients whose primary reason for referral was stroke rehabilitation, irrelevant of the time post-stroke. So yes, so I would agree with that.
So it's just, so we'll be asking you for that question to be answering for the people that are being referred for therapy, not the 6-month review referrals in that question. That's what we're saying. Is that right?
Yeah, I think sometimes, I mean, I totally get that there will be additional people that aren't on the books that come in just for the 6 months review. And whilst, you know, again, none of this is simple, whilst obviously doing the 6 months reviews and an additional task that the teams are participating in, for the purposes of the whole time equivalent staff to patient ratio, we need your team to return so that we can look at it in comparison to other teams who perhaps don't offer a 6 months review. So we just need a sort of even level playing field for that, if you see what I mean.
Yeah.
But it's a valid point. Sorry, I didn't catch the lady's name. Absolutely.
That makes sense, and that's what I thought, but I just thought I'd check.
Yeah, but
Lovely.
please don't think that we don't understand the additional, you know, the wonderfulness of doing 6 months reviews as well, because it is fantastic. Yeah.
And obviously
Hi,
later on, sorry, as you said, Kirsten, there is a section later for you to tell us about the 6-month review structure, who's delivering it, where is it based, all of those sorts of things. So that information isn't lost. The only thing that I would add to that then is that if you have, sorry, I think we've got a bit of an echo. If you have dedicated staffing that was allocated to that 6-month review part, when that was added onto your service, say it's a day a week of somebody, you might want to take that day a week, if that is dedicated purely to the 6-month review part, you might want to take that 1 day a week out of your whole time equivalents, because otherwise that will be artificially bumping up your rehab staffing if you're going to take those 6-month review numbers out. Okay, so for question 1.7.
Sorry, can I ask a question?
Yep, I'm not sure who it is that's asking, but please do. I can't quite see.
It's Martina. Hi, I'm
Martina.
sorry, I lost sound there at a crucial part. So we are including the 6 monthly reviews in the last 7 days. I just want to clarify that because I lost the sound when you were answering that question.
So for that, the team that have asked the question, we are saying that particular question is around therapy. So people that have had therapy within the last 7 days.
Okay.
So if they have received a referral just for a 6-month review, we wouldn't capture that in that.
Okay, only if it was for therapy.
Yeah.
And are you including, let's say, inpatient community rehab hospital? So we're a mixture. Our community service is a mixture of community rehab, domiciliary, and we also have 25 inpatient beds in a community hospital. Are the inpatient beds to be included as well?
So those inpatient beds should have a separate registration.
Okay, so we haven't actually set that up. So I do need to do that, even though it's not an acute hospital, because the acute hospital will have its.
Yeah, so they would be registered as non-acute inpatient beds.
Okay.
All right, we can pick that up with you after, Martina, if you need some help to get that looked at. The team would need to be separated between the inpatient beds and that being registered with that activity, and then your community input.
Okay,
Can I just
that's
ask?
fine. And can I just also just clarification for question 1.7? If the service, let's say orthotics or dietetics, are available within the trust, but we're in a separate, obviously, domiciliary cluster, do we include that? So it is still available within our service, but not necessarily locally. Do we answer yes, but not within service, or is that still included within our service if it's available in the trust?
So it's yes, but not within your service. So it's available within your trust, but not within your core team.
Okay, perfect.
So
Thank you.
actually, we could probably reword that to say yes, but not within our, not within this core team that's registered. So within your trust is fine, but just answer that as yes, but not within your service. Thank you.
Okay, thank you.
Just going back to the North East London team, because there was another couple of questions on this same point. So for question 1.7, we have a SALT post for stroke funded within the service and others for stroke and neuro that are funded through SALT but sit within the service. Should this all be put within the service for ease? I'm not sure that is quite clear, the question, but if they are all operating within the team together, put it in together. So add those both in. Hopefully that makes sense to Kirsten, who submitted the question. So put that all together for ease, that's fine. And then the last question here from that same team were that we cover 2 boroughs. So for dietetics, I think in one borough, we have a dietitian who is funded outside but sits within the team. But for the other borough, they do not sit within the team and we do not have access to the numbers of referrals they receive. Oh dear. So I'm unsure what to do for question 1.7. Would it be best just to use the information for the one borough? So I think what we need to kind of come back to for this is what does the data, what's the purpose of the data? And the purpose of the data and this whole exercise is to show variation and for this to be able to be used locally to be able to drive improvement. So I think if your data is, if you just use the one for the service that's in the one borough, then I think that's not going to show that variation. So I think what you probably need to do is have a bit of a look, and again a pragmatic view about the number of referrals, going through the caseload and looking at what's happened, giving a rough number of those total referrals across both boroughs, and then again the waiting times, having a look across both boroughs, and then telling us what you think the average is between the two. I think just reporting one borough isn't going to show the difference between the two. Okay, so that's question 5. Question 6 then. Right, this one is about orthoptist services. So this is a standalone single discipline service in Warrington and Holton, orthoptic stroke service. Brilliant, I've had a question from you, thank you. Okay, there's lots of questions from them actually. So let's quickly run through this. So 1.4, can you whiz back up to 1.4, Fariat? Okay, so does this mean treated on the ward or outpatient service or both combined over the 7-day period? So for the standalone services, it doesn't matter where you're treating them, how many patients have you seen wherever that was for that 7 days if you are a standalone service. Okay, for relevance, our standalone orthoptic service sees patients on the ward, then after discharge follows them up as an outpatient. Some new patients will go straight to their outpatient appointment as their first appointment. Right, okay, so 1.5, does this mean actual referral to the service or number of new patients seen in the 12-month period? How many new referrals of people with stroke has this service received in the last 12 calendar months? So Faria, do you want to clarify that with the help notes there? So the question is, does this mean actual referrals to the service or number of new patients seen?
So this refers to new stroke patients who have been referred and accepted to this service within the relevant period.
So it's the referrals, not the patient seen. Yeah. Okay, so hopefully that answers that question. And then for relevance, we get referrals from other therapists, stroke consultants, GPs, etc. But we also see every patient admitted to the stroke ward, whether they're referred to us or not, to assess if they have a vision problem. That sounds good. As many will have no symptoms, but will have a problem. So do we need to count those just referred to us? Or do we count everybody that's been seen? So I would say if you are, if you've got a blanket referral system, so you're not necessarily waiting for kind of paper referrals to come into you, count everybody that you would have screened and accepted into your service. So not just the ones that have come from elsewhere, everybody that's come into your service. Okay, and then there's another question about 1.7. I think that this is probably quite specific to the standalone services. So 1.7, I found this question very confusing, and I wonder if others will struggle with it too when they are a standalone service. We work, as I mentioned, on a stroke ward, as well as seeing ophthalmology patients in an outpatient department. Obviously, patients on the stroke ward will have access to other therapists. Okay, so for a standalone service, you are just reporting what is within your service. So if this is the orthoptist team registered, they for 1.7 will only be answering the orthoptist part of that question for 1.7, and you would be putting 0 in the rest, because the services that you're working alongside, the inpatient unit, for example, will have already registered and will be inputting the rest. Okay, so the inpatient ward that orthoptist team is supporting will say that they have access to orthoptists that's with it, yes, but not within their core team. That's you as a standalone service. You on your registration, registered as a standalone service, are only reporting the whole time equivalents of the orthoptist department. Okay, so hopefully that makes sense, and that's the same for other other standalone services such as outpatient services, neurophysio outpatients, and things like that. Okay, just report the whole time equivalents of the service that you're reporting that you're registered as. Okay, so I think that's all of the questions for the orthoptist team. So thank you for those. I've now lost question 7 though. Oh, okay. Question
Louise,
7.
could I just interrupt before you go on to question 7? I've been, because I'm just looking to see what question 7's about. Is that there's just quite a lot of chat around 1.7, and there's just something I wanted to pick up around
Rebecca.
Stroke Association 6-month reviews. So this is a question about standalone 6-month review provider who I've just been checking who will I think it's the Stroke Association who will be asked to complete section 1 and 4, and so section 1 does require them to complete 1.7, and so the whole business around whole time equivalents just for therapy was worrying the person, quite rightly so. But in the instance where you're completing this just as a standalone 6-month review provider, you would return the whole time equivalents, I'm presuming, for just patient, family carer, support worker, and in which case your referrals would be your 6-month review, your total number of referrals for that 6-month review. So if you're just responding to 1.7 as a 6-month review provider, then it's slightly different to if you're returning 1.7 as a community rehab team, if that makes sense. Because I think it's just a kind of anomaly of the form that we're asking 6-month review providers, standalone ones, slightly more information.
Thank you, Rebecca. That's helpful.
Sorry, can I
that
just...
makes sense to people.
Thank you, Rebecca. That's really helpful. Sorry, it's Esther from Stroke Association. Can I just check then that the answer for the yes, but not within service, because we would, as a standalone 6-month review provider, refer back into the teams, but we wouldn't have any of the details around waiting times, etc. So while we
I think
no.
Just answer no, yeah. I mean, of course, we know that you would refer back. That's the whole point of 6-month review providers. But the primary aim of that question as a whole is just to make sure, from a therapy perspective, the patient's getting access to the whole multidisciplinary therapy team. That's really what it's about. It's less about re-referring back, which I know is an important issue, but we can't answer everything, ask everything in one question, if you see what I mean.
Yeah, that's fab. Thanks so much.
Thank you.
Lovely. Okay, so that goes the same for all standalone services. The question that Esther's just asked there. So you are just reporting for the staffing within your service, and it's a no to then all of the other disciplines there. Even if you're referring back across the pathway, you don't need to worry about that because you're registered as a standalone service, and the re-referrals to those other services will be picked up in other registrations. Okay, thank you very much. That is really helpful. Okay, so question 7 is again about community rehabilitation beds. So this is from a CRT in Seaton, Axminster and Sidmouth, and looking at the number of stroke patients seen over a 7-day period. So those rehabilitation beds should be captured separately. So they should have their own, if they see more than 20 stroke patients a year, they should be registered separately as a non-acute inpatient unit. So it may well be worth going back to that service to see whether they're registered. Okay, so I don't know whether the Seaton, Axminster, Sidmouth team are on the call. So if you are, then let us know, and hopefully that answers your question.
Yeah, that's me, Martina. Yeah, so I'll have to check the exact numbers because I've just taken a post here. So to see how many they usually see, but I do think they will be seeing more than 20 a year.
Right.
As in, you know, just on the journey from acute to home. So
yeah.
So it does sound like I will have to set up another non-acute SNAP data.
Okay, so it would be worth, Martina, you getting in contact with Fariat around the possibilities of that, and then whether that is or isn't possible will determine whether you'll need to exclude them from your CRT data regardless. It's just then whether we unfortunately lose that non-acute inpatient data because we've not had them registered, or whether we can still squeak them through, and then we obviously would need to reach out to that non-acute inpatient unit to encourage them to get their information in.
Okay, so it's a general non-acute unit, so it takes everything. So it
yeah, that's fine.
Stroke specific, yeah.
Yeah, so they would register as a general service, and then they would tell us the total number of patients that they see a year, and of that, how many of those are stroke. And then on 1.7, if this service is to register, they would say that they do have access to OT, physio, speech therapy, etc., but not within their service. And then it asks them, where does that come from? And that comes from you, from your team. Does that make sense?
Yeah, only if we have greater than 20 patients a year.
Absolutely,
that's separate.
Yeah, they do. Okay. But otherwise, then your CRT data does need to exclude that inpatient element.
Okay.
Okay, so the next question, Martina, that's okay. The next question from yourselves is it only patients with a new diagnosis of stroke who are included? I'm assuming old strokes who are re-referred are not required, or is there a timescale on this? Can I get clarification on this, please? So we have clarified this, I think, in the help notes. So, and we appreciate that this is a little bit confusing. We are saying any stroke referrals who have come to your service within the year. That doesn't mean that they have to be immediately post-acute. All right, so they can be an older stroke that has been referred to you for a primary need of stroke specialist rehabilitation. All right, so if you're a general team who is seeing somebody who happens to have had a stroke in the past but is actually referred to you because they've got a fractured NOF, then don't count them. If they're being re-referred at a year post-stroke, say, for a stroke-specific need, then we would ask you to count them. And again, the reason for that is that we think it's too hard to be asking your teams to go through all of the referrals and work out when was their stroke, when, you know, are they immediately post-acute, and separate out your data. So all strokes, please, if they have been referred to you for a primary reason of stroke rehabilitation. Is that okay?
Yeah, thank you very much. Yeah, that's helpful.
That's okay, and that's obviously relevant for all services. That's the case for everybody. So that's helpful. Thank you. Also, if patients are discharged from SNAP as an inpatient but still come through our service for ongoing rehab, are they to be included? Yes. Yeah, absolutely. So again, if they've been referred to you for a primary reason for stroke, be that management or rehabilitation, slow stream or ESD type rehabilitation, then please do include them. All right, doesn't matter if they've been discharged from the 45 minutes on SNAP acutely. Okay, lovely. So thank you for sticking with us so far, everybody. I know this is quite detailed stuff, but hopefully some of the things we're covering are relevant for other teams as well. Let's go to question 8 now. So this is from Claypon's inpatient neurotherapy team, which is a non-acute inpatient team. So question 8 are asking, where the audit requests whole time equivalent numbers for the different disciplines, should I put the number of posts and then in head count the actual number of bodies? So for example, we have 4 whole-time equivalent OTs, but the actual head count is 3 because 1 is a vacancy. How should I enter this? So again, a really helpful question, relevant to everybody in terms of the head count and the whole-time equivalent bits. So if the vacancy, if there is a plan and an expectation that that will be recruited to and it's staying in your establishment, tell us that that post is there. So tell us that you've got 4 whole-time equivalents budgeted and you've got 4 as your head count. If that post is frozen and is going to be removed from your service, then tell us that you've got 3. All right, but if there's all plans and intents and purposes to recruit to that post, tell us all of those people, because otherwise you're going to be caught short in terms of your therapy numbers. All right. Okay, and then the last question that we've had before the meeting, and then we'll go through to the chat, is from a 6-month review team in Lewisham. Doesn't have the estimate of the number of referrals to their team as the lead has only been in post for 6 months herself. Okay, so this is again relevant to any type of service that hasn't been in existence for a full year. And so what we'd be asking is for you to, again, have some pragmatism. So look at the number of referrals that you have had across the period of time that you've been open and scale that up to what you would think would be a best data-informed estimate for a year's worth of activity. Okay. So that's the same for any newly formed service. Look at what you have got in the time frame and then work that up to what that would indicate over a year. Okay, thank you very much for everybody that submitted questions before. Rebecca, have you got a handle on what's in the chat? Do you want to take us through anything else there?
Yeah, so there are a couple of key questions in the chat. And I might draw on people in particular, but just to go to the whole time equivalent business first, because so somebody has asked, we are an intermediate care team and see all patients, 2 PTs and 1 OT, see the neuro in varying proportions. We have admin days where we do triage. Should we add these triage days to the whole time equivalent? I mean, from my perspective, it's more to do with what is the whole time equivalent that team is commissioned for, and return that, much like we've said before. As long as we've got the information about numbers of stroke patients in comparison to all patients, then we should be able to determine. So it's less about what they're actually doing, it's more to do with the whole time equivalent. So hopefully that makes sense. So there's another one that says 1.7, some of that list are provided within the service, but others are not. How do we capture this? Fariat, as far as I can understand, in the actual web tool, you can show which is provided by the service and which isn't. So it's on a discipline basis, you can do it for each one, is that right?
Yes, so for each one, A to M here, you'll be able to indicate if yes within my service, yes but not within my service, or no. So for each one of those, you have these 3 options to indicate. So
it's not a blanket kind of thing. It's for the whole. You'll be able to do it each in turn. So there was another question who said, have I missed 1.5 or 1.6? We have answered the 1.5 number as we are a stroke only service, but 1.6 is for stroke and neuro. Do we put the same answer in that box or leave it blank? I would have expected it to be greyed out. So again, there's some questions which I think will become clearer when you're actually interacting with the web tool, but may I just check that, Fariat?
Yeah, so in terms of, I think what the person's saying is that they're a stroke only service. So the numbers for correct me if I'm wrong if the person's on the call, but the numbers for 1.5 and 1.6 will be the same. Is that
Yeah.
is that if
Yeah.
if that doesn't
Hi, I
answer
am
that.
on the call. Yes. We've been on the audit, and it doesn't grey it out. It doesn't grey out 1.6 if we're saying we're only a stroke only service. So I don't want to double count our patients. Are we putting the same number in both boxes, 1.5 and 1.6?
That's correct.
Lovely. Thank you very much.
Great. Oh, I love a question where we can get the answer right. So the other point that which has come up and has actually come up in the frequently asked questions, so we've had this question before, is all around time from referral to being seen first contact, which is obviously a clinical audit question, but again goes back to waiting times. So I think there's a couple of people in the chat who, I think Claire Lee, hi Claire, asked it in relation to some of the, I think it was dietetics. So whether so there's two questions. One is in terms of whether people know what the time of referral was. And in the frequently asked questions, sometimes we've said that if nothing else, that has to be the hospital discharge date if there isn't another way to determine that, which is not ideal. And I know there's lots of potential delays in between, but I think in the end we kind of, Fariat, I think we that's what we agreed on when we did it in the frequently asked questions. That's the first thing. The second thing is a lot of people are saying, but we just don't know. Or it varies from patient to patient, and I think where best you need to give your best guesstimate or your as best as you can, being pragmatic, as Louise said from the top. So you know, a kind of as much as you can idea about what the probable waiting time will be. And there was another question again relating to that, which said that we're referring across multiple services, across multiple county boundaries. Well, there'll be a variation in waiting times. But, you know, it's kind of giving us the idea, what is that? Is that a couple of days? Is it a couple of weeks? It's really on that kind of level that we're, if you aren't able to be more exact. So does anybody have any additional comments on those two topics?
Similar, but it was about if the disciplines don't sit within your service. So I mentioned the doctor's quite a good example, because for some of our patients in ASD, we will want them to see the GP immediately or the next day, or obviously call 111. Then there's the referring back to consultants, and it's like a doctor. If it's a GP, it's going to happen within 2 or 3 days. If it's a consultant, it can be a couple of weeks or wait till your 6-month review. So there's quite a big difference.
Yeah.
So it could, do we put in the 1 day, 2 days, or do we put in the 2 weeks, 3 weeks?
Yeah, and I guess there's a couple of things with that in that doctor for an ESD, I mean controversial, doctor for an ESD service, we would be referring to the consultant primarily, because the consensus would suggest that you need some kind of consultant input. So it'd be more relevant to that. Obviously, that's not saying that GP referrals aren't important, but for that specific question, it's the consultant that we're interested in.
That's helpful. Thank you.
No offence to GPs, because they are important as well.
Can I just clarify that you were saying, you know, from the referral to first time they've been seen, we're okay to take that as discharge, because sometimes we might get, like for our complex patients, might get a referral before they've been, like way before they've been discharged.
Yeah, and I know Louise Claire, we've talked about this a lot, and in an ideal world we would have time for referral, time from the time of discharge and the time that first contact, but we don't. And I think again, there is obviously an issue between referral and discharge, but I think key for us is just understanding waiting time, particularly at a transfer period where patients are out of hospital and not being seen. So use that.
Yeah, that's fine.
Yeah. Okay. Is there anybody? I'm pretty sure we've covered the majority of questions that came up in the chat.
I think there might be a few extras now, Rebecca. So shall I just quickly jump to those?
Yeah.
Alicia, I don't know whether you feel that we've answered your question. Our whole-time equivalent is not funded by stroke services, as orthoptists is funded by ophthalmology. Would I still say the whole-time equivalent of the sessions that we cover? So I don't know, Alicia, whether you are registered as the inpatient team or whether you are registered as the orthoptist service. Are you there?
Hiya, yeah, I am. I'm registered. I think the parts I have to fill out is 1 and sorry, I think I have to fill out 1 and 4 and vocational. So
okay, so sorry, which service are you registered as? Are you registered as the orthoptist service, or are you registered as so you're the orthoptist service? Fine.
Yeah.
Standalone service, fine. Okay. So yes, you would still say the sessions, you would register your whole time equivalent for all of your work. All right, so I think we probably have answered that question actually. So all of your work as a standalone service would sit in your whole time equivalents as a standalone service.
Brilliant, thank you.
And it doesn't matter about the funding, that's fine. Okay, Sarah Coleman is the next question in the chat. In the questions asking if referrals have increased, decreased, or stay the same, is this in comparison with the year before? So really what we're getting at in those is, has COVID drastically changed the landscape for you? Or has there been any significant other change in your pathway that's made things different? So yes, compare it to the year previous if you think that the year previous was a standard year. All right, so really has this changed as a result of COVID? All right, so hopefully that answers that question. Martina has asked, can the document that we are sharing at the moment be emailed? So this is already on the SNAP website, so that's the best place to go for that. These are the help notes, so you'll be able to access that on the SNAP website, and also the frequently asked questions is updated and is on there as well. And then Sarah, I think we have answered that question just in terms of waiting times. So I think that's the question that Rebecca has just answered. And the last question there, Charlotte Ryan, does joint care planning count if patients are given the document that states they have a package of care from social services? So really the nature of that joint and health and social care plan is that it's one document that's summarising their health and social care needs, and how those are going to be met kind of in a joined up way between joint and health and social care. So a document that has been purely written by health that just has one line about a package of care probably isn't truly meeting the requirements of that. So in the help notes there under 1.9, does this help give us any more information? So they have a document that it should be patient-centred around that person's individual needs, that documented evidence of joint care planning between health and social care for post-discharge management. So yes, I guess if it has got the package of care and the ongoing input that's going to be given by social services, that would count as a joint health and social care document. So that is fine. And then Martina, on an ongoing basis, what information will be required to fill in, e.g. monthly? So for all teams, especially teams that haven't engaged with this audit before, by being involved with the post-acute organisational audit, which this is, there is no ongoing obligation for you to give us monthly data or ongoing clinical data through the clinical audit. So those two audits are separate. There's the clinical audit, which has all of your clinical information that you upload as you go all of the time. And then there is this separate audit. There is no obligation, as I've said, to give us ongoing data. We would love you to, and we can have some discussions about how that works and what that looks like. So anybody that is as part of this post-acute organisational audit, we would also love to have your clinical data, but you don't have to. And we would be asking all services to engage in this task again, probably in 2 to 3 years' time when this is all repeated. Okay, so I think that is all of the questions there. We are just coming up for the end of time. So just to reiterate to people, a big thank you. Sorry, that was probably not the easiest to listen to and to get excited about on a Friday morning. Oh, we've got an echo now.
Sorry, Louise.
Yeah.
I just have one question just on the chat, just about the referral numbers. It's Lisa speaking.
Hi there.
Hi. When you talk about referral numbers, are you talking about referrals into the team, or are you also then including the internal referrals that might be generated?
So it would be both of those, Lisa. To capture your total activity, we would say both of those. All right, otherwise you're going to be selling yourself short of what you're doing. Okay, so just to round up and finish off, so a big thank you, everybody. I hope that has answered some of your questions, and some of them, whilst they sounded quite specific, actually are relevant across the board. So thank you to everybody that's asked questions. If you still have any questions, then do get back to us. If there is any further clarification required, then obviously let us know. It isn't an exact science, so I think go back to what's the purpose of this. And the purpose of this is for you to be able to show the reality of your services, to be able to drive local improvement. So if you keep that at the heart, then that should guide hopefully what you do, how you submit the data. We've got weekly sessions like this, as we've said, so come back to us again. The help desk is there in between times, and we're on email, so you don't have to wait for those Friday sessions, and we absolutely are here to support you through the next few weeks to try and get this uploaded. It is really appreciated. We know it's not an easy time still, and we know that it's not a small amount of work, so thank you very, very much. Thank you for joining us. We'll update everything as a result of today, and we'll upload this webinar so that you can go back to it if you so desire. But just to finish off, say enjoy the rest of your Friday and have a nice weekend, everybody. And thanks again for joining us. Take care. Thank you.
Thanks, everybody. Thank
you.
Thanks.
Is Farriet there?